interested in different ways in our world, which is the so-called developed countries, interaction between cardiology and cardiac surgery, which is becoming from two separate specialties, they have merged nearly into one. This is something which is happening extremely rapidly in our world, and also in humanitarian actions in developing countries where the problems can be quite similar to developed countries. However, they remain for the time being a little bit separated, and perhaps it is a mistake, but they need perhaps some time to catch up.
You do a lot of work in cardiology around the world. What role does precision health currently play in your work?
I think that as soon as a human being intervene, precision becomes questionable. So I think that we are being helped in our specialty like cardiology or cardiac surgery. We're being helped by electronics, by imaging, by a lot of diagnosis tools, communication, assessments. As far as the therapy is concerned, it has been refined a lot, but still it remains on a human interpretation. And even if you use tools such as robotic, perhaps people might think that the robot is doing everything. The robot is not doing everything. You need to guide the robot, and you need to know the surgery to use the robot. Yeah. And probably robots are still at their infancy. For instance, you don't have any tactile feedback with the robot, which is something which is missing in order to do refined surgery. The precision medicine can be seen as a remote diagnosis. For instance, you look at the third world countries, such as in Africa, where you have an endemic rheumatic fever. A lot of kids in the bush, you don't even know how they're doing. You could, for instance, use a portable echo machine with a technician, not a physician, do an echo to screen all the people, send that to a hub of specialist tertiary care in valvular heart disease, and then you could probably tell the patient that he needs only medical therapy or surveillance or surgery within 6 months or a year, which is not done yet. So there are lots of aspects which, doesn't make this specialty as precise as one would like to or might believe.
Dr. Gilles, what do you make of the challenges in data, and how can we solve them?
We all have in all specialties some guidelines which are derived from publication, results of randomized trials, and sort of accepted good practice, good medical practice. Should we get out of these guidelines or should we not? This is the first question to which we do not have a straight answer. Now, the society wants security. So if you want security, you need to apply the guidelines. Otherwise, you can be sued. But sometimes to treat an individual patient, you need to get out of the guidelines. So this is the first thing. The second thing is publications. Publications require, first of all, tremendous scientific knowledge, and especially in statistics more than ever. So they need to be accurate in terms of statistics. They need to be funded. And the problem is, where do the money come from? Because to do a long trial with thousands of patients, and most of them should be prospectively randomized, so you need to start one there and then finish, and what are the primary endpoints, secondary endpoints, and define what you want to demonstrate. In order to do that, you need to use the same treatment. Everybody needs to use the same treatment, which, for instance, in cardiology is not the case. Every surgeon, every cardiologist has his own tricks and tips. Whereas, for instance, in oncology, they have protocols. And so the best oncologist can use the same treatment as someone who would not be as good. As soon as you introduce a human parameter, you create a deviation in the standard results. And so we need this publication. We need prospective randomized trials. We need longitudinal studies. We need serious publication, not rubbish publication. And unfortunately, to maintain academic position, the medical world requires to publish a lot. Yeah. And perhaps there are too many publications. So it doesn't mean we should not publish. Should be able to discriminate those good from those bad publications. The current environment is getting every day more complex. You have the patient at the center, and then around the patient you have the pressure of internet and the media, where the patient gets informed. You have the publications, yeah. You have the insurance, you have the manufacturers, and you have the cardiologists and the surgeons who try to find what is, during what is called the heart team, the best option for a given patient. Now, what happens sometimes is that either the industry pushes very much to get their product used because they have some financial feedback, which is, of course, understandable, otherwise there would be no progress. And you also have the patient information who comes and says, I want this and I don't want anything else. Yeah. So in the middle of all that, we need to try to do our best to make the patient understand that we will try to do the best for him, which is not perhaps always what he thinks is the best for him. Yeah. It's very difficult. Information is good, but too much information or misinformation is bad. Yeah. The seek for precision is, of course, something we need to have in the back of our mind. I'm just a bit dubious about the fact that we can be as precise as the environmental technology around us. Computers, MRI scans, CT scans, echo, biochemistry, physics are precise. Will medicine be precise? Even for very simple things like you have 3 coronary arteries, and to decide whether the best treatment is medical treatment or stents or surgery is still under debate after 20 years, despite all the knowledge we have on this. It looks very simple. It's so complicated because there are so many parameters. Perhaps artificial intelligence will tell us. But it's a seek of precision rather than precision.
Yeah.